right, so we're gonna recap. Six. Dr. Forrester, you there?
Yeah, can you see me? Can you see me?
No, I took off the
the camera.
the camera. Yeah, because since we're doing the presentation. Lenny, you there?
Yeah, I'm here.
Yeah, I'm here. Noel?
I don't see Noel.
Fell off. Okay. Yeah, there's some feedback from.
Yeah, hear me?
All right, just give me 2 seconds and we'll. All right, so we're going to go back over valvular heart disease. Okay. We're going to go back over aortic stenosis and just 1 second. Okay. All right, so we're going to go back over aortic stenosis. It's very, very important. As I said, Greg can let you know. In any one day, he has 2-3 patients with aortic stenosis. Usually senile degenerative aortic stenosis, but nonetheless aortic stenosis, very common in the elderly population. As we have said, valvular heart disease, basically heart disease affecting the heart valves, and you have the aortic, mitral, tricuspid, pulmonary. The most common, of course, is the aortic and mitral. We're going to spend a lot of time on those. But the tricuspid and pulmonary valves are also important, and we will do those when we do the right side of the heart. We'll spend a little bit more time on those. Valvular heart disease is very common, as we have said, especially aortic stenosis, aortic insufficiency, and mitral regurgitation. Those are very common valvular problems. Some of the signs and symptoms, leg edema, as we have said, that's a venous problem, because the right side of the heart is not functioning properly, either because of the pulmonary pressures are up, or you have a decrease in the right ventricular systolic pressure. So that pressure builds up into the venous system, and you'll get leg edema, leg swelling. You have ascites, which is fluid in the abdominal cavity, and then murmur. We're going to start over with aortic stenosis, and the murmur associated with aortic stenosis is what we call an ejection systolic murmur, which is heard best at the base of the heart or the left sternal border. That murmur radiates to the neck, or what we call the carotids. Okay, so that's sort of specific for aortic stenotic murmur. Depends on the type of valvular lesion. You can get cardiomegaly, which is the heart enlarged. With aortic stenosis, you'll get thickening of the heart muscle. Hepatomegaly for the same congestion problem we talk about. If the pulmonary pressures is up, then it's going to increase the pressure in the venous system. So if you have pulmonary hypertension, it's going to increase the pressure in the right ventricle, pressure in the right atrium, in the inferior vena cava, and then the liver is going to be enlarged. Tachycardia, that's increased heart rate, which is another sign of a valvular heart problem, usually decompensated when the patient is not doing very well. And you can get a third heart sound and a fourth heart sound. We'll discuss those another time. We're having a little problem. No, it's not the heart, it's not moving, so I need to escape. Just 1 second. Is this sitting flat? Is this sitting flat? No, it's not. No, but that's not. That's how it was the previous week. The slides are not moving forward. Just give me a second, guys. Sure. Let me see, I might have too many of these. Okay. Yeah, so sometimes it's just stuck. I'm not sure what's going on there. It's just doesn't want to move forward. All right, so we'll say aortic stenosis. I mean, you have to know how to assess aortic stenosis. And we're going to go through some maneuvers, and we're going to also discuss some of the problems related to evaluating aortic stenosis. And Greg, you need to pay special attention to this because it's going to be on your exam. They want you to know, where you can get the errors, where you're going to get errors in evaluating a patient for aortic stenosis. So it's important that you follow. I put some slides at the end. You weren't there the last time, so those are exam slides, so to speak. All right, so let's just move into aortic stenosis. So the normal size of the aortic valve is about 3 to 5 centimeters squared. You have to know that. And when you have aortic stenosis, the opening of the aortic valve is restricted. It's not opening to its full extent. And when you look at your echo, especially if the first view is you should get the parasternal long axis view, you'll see that the valve is probably thickened and it's not opening properly. That's going to tip you off that this patient has aortic stenosis. And then there are certain things you need to measure in the parasternal long axis view. You want to measure the diameter. Okay, we're going to go over all of that. So some of the signs and symptoms of severe AS, shortness of breath and exertion, because the cardiac output is fixed. So if you do any type of exertion, you cannot increase the output from the heart. So the patient's going to be short of breath. Syncope and sudden cardiac death is another very important feature of aortic stenosis, because we say the cardiac output is fixed because of the obstruction. So with any type of increased demand, you cannot increase the output to satisfy the demand, the patient will pass out. So one of the indication to do surgery on aortic stenotic valve is if the patient passed out. Sudden cardiac death, that's usually due to arrhythmias, okay? So the patient would have abnormal rhythm, usually VT or VF. And those are, you know, especially VF is a terminal rhythm. Fibrillation. Huh? Fibrillation, yes. Ventricular fibrillation. Chest pain because of subendocardial ischemia. So decreased blood flow to the subendocardium. Okay, so that will give you chest pains. And I would say you get this ejection systolic murmur at the base or the left sternal border, which radiates to the neck. So these are some of the features of aortic stenosis. What are the causes of aortic stenosis? Senile degeneration is usually age-related. Older individuals, 80s, 90s, will have senile degeneration of the aortic valve. They become calcified, restricted. Okay, those patients usually are hypertensive as well. And they may have some other atherosclerotic disease process going on. The most common cause, however, is bicuspid aortic valve, which accounts for about 30 to 40% of cases. In the US and Europe, about 50% of all patients going for aortic valve replacement is because of bicuspid aortic valve. Acute rheumatic fever can also cause aortic stenosis. And worldwide, this is the most common cause for aortic valve replacement worldwide. Yes, rheumatic fever. Endocarditis, because vegetation obstructs the valve, that can also give you aortic stenosis. All right, so as we have said before, how do you evaluate, how do you assess aortic stenosis? So in the parasternal long axis view, you look at the valve, and you can see here that the valve, you can see the valve is not opening fully, okay? It's thickened, and it's not opening to the full extent. In systole, you can see we're right in the T wave. The aortic valve should be fully open, right? The mitral valve closed, and the aortic valve should be open. You can see it's thickened and restricted. So one of the first things you have to do is measure the diameter of the left ventricular flow tract. And the diameter is measured. You have to note the position that you're doing the measurement. And it's just in front of where you see the valve, you know, a couple millimeters from the valve. And you're going to measure from the tissue blood plane to the tissue blood plane right there. Okay? Note the position that you do your measurement so that whenever you go back to do any measurement, it's measured at the same point. Okay? So in the parasternal long axis, again, this is your septum, this is the posterior wall, the mitral valve, the left atrium, the aortic valve, and this is the aorta. This is the right ventricular flow tract, okay? So that's where you do your left ventricular flow tract diameter. So in the short axis view, you can look at the aortic valve. Important in the short axis view, you need to see the aortic valve open. You need to look at the opening. And if you can do planimetry, it's not very an accepted approach for valve measurement, but you can do planimetry. The problems with planimetry is if it's heavily calcified, it's difficult to trace the orifice. And with planimetry, you have to get that smallest area. So you don't know, you have to do multiple assessments in planimetry. And what we know in aortic stenosis, the important thing is the effective orifice area, not the anatomic area. There's a difference. When we plane the area, that's an anatomic area. But when we do our calculations describe an effective orifice area. So it's not, and it's usually smaller than the anatomic area. But clinical, the disease process or the burden, the clinical burden is really, the clinical burden of aortic stenosis is dependent on the effective orifice area, not the anatomic. So the prognosis is dependent on the effective orifice area. So even though we can do planimetry, we don't use it a lot, okay? But you get it in the short axis view at the level of the aorta. You want to see the valve open. And you want to see the valve open because if you can see if it's a bicuspid aortic valve. Bicuspid aortic valve, then when the aortic valve opens, it opens in a triangular shape. If it's bicuspid, then it will give you a football shape opening. Okay? So assessment in the short axis view is very important. All right? With M mode, and we'll go over M mode at some another lecture, you can also see thickening of the valve and decrease cusp separation. So this is our two-dimensional image on top, and we have the cursor passing through the chest wall. So the cursor passed through the chest wall, the right ventricular wall, the right ventricular outflow tract. It passed through the aortic wall and the aortic valve and the left atrium. Okay, and if you look down the bottom, this is the M mode. The chest wall is here. This space in here, this is the right ventricular flow tract. This is the aortic wall. So this one portion of the aortic wall, this is another portion of the aortic wall. The aortic valve opens in a box shape right here in systole, aortic valve open in systole, and it closes in diastole. So this is diastole. Okay, so you always gate your echo images. So systole, it opens in a box shape, and diastole closes. You can see. Important with aortic stenosis. So this is normal, and this is case with aortic stenosis. Okay, you do the same sort of cut. You can see that the aortic valve is thickened. It's open in systole, but it's thickened. It has a box-like configuration. And then it's closed in diastole. You can see the valve is thickened. The cusp separation is restricted, is reduced, and you can see that. So the M mode can also tip you off that you're dealing with aortic stenosis. So in the 5-chamber view, you want to do your left ventricular outflow tract time velocity integral. And we spent a little time on this before. You want to be outside of the zone of turbulence. So you want to be about 1 to 1.5 centimeter away from the valve, because you don't want to subject the LVO to TPI, to turbulence. It's going to be, you're going to get a number which is higher than the real number. So you want to get outside of that zone of turbulence and do your left ventricular outflow tract TVF. So in the 5-chamber view, so this is our 2D image on top, Okay, this is our cursor here. This is the left ventricular cavity. This is our left atrium, mitral valve, and our aortic valve is right inside there. So just outside of the zone of turbulence, you put your cursor, point of interest, and you get your left ventricular flow tract envelope, and you just trace it. Once you trace it, or you do planimetry, you get a velocity time integral. In this case, it's 26.6 centimeters. Okay? Another important thing when you're doing your, so that is the left ventricular flow tract, TVI. Pulse rate. That's a pulse wave. So the left ventricular flow tract TVI is done using pulse wave. When you do the velocity time integral across the aortic valve, you use CW, continuous wave, because you're talking about higher velocities. Remember, velocity 1.5 meters per second or less, CW. Velocities greater than 1.5 or 2 meters per second, CW. So high velocity, use CW, low velocities, use pulse wave. All right, so to assess the aortic valve now, you put your cursor, so you have your 5-chamber view on top, right here, left ventricular cavity, mitral valve, left atrium, aortic valve is right there, and you put your cursor in the aortic valve, the point of interest in the aortic valve, and you get your CW, continuous wave Doppler. And you trace the envelope. Okay? It's important to interrogate the aortic valve from multiple windows. You want to get the highest velocity. Remember when we did Doppler, the angle theta is very important. The greater the angle, the lower the velocity. An angle of 90 degrees, you're going to get 0 velocity. So the cosine of 90 is 0. The cosine of 0 is 1, so you want the flow as parallel, the beam as parallel to the flow as possible. So you want that theta to be 0. All right, so in this case, you see the peak velocity is 2.72 meters per second. And of course, remember the gradient is, the mean gradient is 33.8 millimeters mercury. We use mean gradient, not okay, so we use mean gradient. It's very important. Use mean gradient, not maximum gradient. Okay, so it's mean gradient which is more important in aortic stenosis. So we're doing all this calculations and assessment because we're going to use the formula. Remember, when we did hemodynamics, we showed how to calculate valve area. So the aortic valve area, and you should always remember, the aortic valve area is equal to 0.785 times d squared, where d is the LVOT diameter, times the LVOT TVI divided by the aortic valve TVI. So that is why we measure d, which is the diameter of left ventricular flow tract, and we measure the LVOT TVI, 5-chamber view. You put your cursor, PW, cursor just outside of the zone of turbulence. Because if you put it too close to the valve, you're going to get turbulence, and that LVOT TVI is going to be higher than what you expect. And then when you do your aortic valve TVI, you put your cursor right into the aortic valve. It has to be done from multiple windows. because you want the maximum velocity. You can see in this case, this was done, it's the same patient, it was done from a different window, and the velocity here is 1.73, just because the angle is different, okay? So the mean gradient is going to be different, the TVI and everything is going to be different, okay? So, okay, and then from this window, you can see that the peak velocity is 3.78 meters per second. The mean gradient is 61. So the window you choose will give you different values for the peak velocity and the mean gradient, which will affect how significant the valve is. So you don't want to use one window and give the patient a lower valve area than they really have. So multiple windows, very important, okay? And then you use when we did hemodynamics, we showed you how to derive the equation. We use the continuity equation. The flow at the left ventricular flow tract is equal to the flow across the aortic valve because the blood is going the same direction. There's no leak in the system. So the flow at the left ventricular flow tract is equal to the flow across the aortic valve. Remember, flow is equal to cross-sectional area times the time velocity integral. So just rearranging the equation, the aortic valve area is equal to the area of the left ventricular flow tract times the time velocity integral, left ventricular flow tract, divided by time velocity integral across the aortic valve. And remember, the area of a circle is pi r squared, and the radius is the radius is d over 2. When you square it, you get d squared over 4. So when you simplify your equation, the aortic valve area is 0.785 times d squared times the time velocity integral across the left ventricular flow tract divided by the time velocity integral across the aortic valve. Okay? So you have to memorize that. You have to know that. I mean, I still use it. When I'm doing anything, I get my D, I get my LVO TVI, the aortic valve TVI, I plug it in the equation, and I see what the valve area is. Okay? Multiple windows. You have to scan from multiple windows. You want that maximum velocity. Well, you also need to use, well, you can, the right parasternal border and the suprasternal notch, depending, okay? And you use your peel-off as well. Your peel-off, that's the imageless probe, okay? You have to memorize that equation because you're going to get situations where you have to calculate your valve. Very, very common. Another important thing, we talk about a dimensionless index. So if the images are not very clear, you can use the left ventricular flow tract TVI over the aortic valve TVI. And if that is less than 0.25, it suggests severe aortic stenosis. So if your images are not very clear, okay, you can use the dimensionless index, which is the left ventricular flow tract TVI divided by the aortic valve TVI. And if it's less than 0.25, it suggests severity. Okay? So you're going to interrogate the aortic valve from multiple windows, apical 5 and 3, the right parasternal view, the suprasternal notch view, and you have to use the pencil probe or the imageless probe. Okay? Remember to let the technicians instruct you how to use the pencil probes. Okay? All right. So we go over all this exercise to come up with a velocity, a mean valve area, sorry, a valve area, mean gradient, and index. So we have to put this into some sort of perspective: mild, moderate, severe. So for severe aortic stenosis, the aortic valve jet is usually greater than 4 meters per second. Okay? And you just have to memorize these figures. For the mean gradient, if the mean gradient is greater than 40 millimeters mercury, it suggests severe aortic stenosis. If the aortic valve area is less than 1 centimeter squared, it suggests severe aortic stenosis. If you're going to index the aortic valve area, and when you index something, you divide it by the body surface area. You use your height and weight, you get the body surface area, and you divide the valve area by the body surface area. If that index is 0.6 or less, if it's less than 0.6, it suggests severity. Don't use this if the patient is obese. Okay? So it doesn't work well if the patient is very obese. And of course, we talk about the velocity ratio or the dimensionless index. If it's less than 0.25, it suggests severe aortic stenosis. Now, for mild aortic stenosis, you have to know what's mild. So if you know what's severe, what's mild, anything that falls in between is moderate. So for the velocity, aortic velocity jet, if it's between 2.6 and 2.9 meters per second, it suggests mild aortic stenosis. If your mean gradient is less than 20 millimeters mercury, it suggests mild aortic stenosis. If the valve area is greater than 1.5 centimeters squared, it suggests mild aortic stenosis. And if the index is greater than 0.85, the velocity ratio, that is your LVOT TVI, to the aortic valve TVI, if that's greater than 0.5, it suggests mild aortic stenosis. Anything that falls in between is moderate. So you have to know what's severe. No, it's the gradient across the valve. It's the mean gradient across the valve. Mean gradient across the valve. So for severe, you're talking about the maximum velocity. So we're using different things here now. Okay, we use the maximum velocity across the valve. If it's greater than 4 meters per second, but we use the mean gradient because we have shown, studies have shown that it's the mean gradient which better correlates with severity. So it's the maximum, it's the peak, yes. Okay? But the mean gradient greater than 40 millimeters mercury. Aortic valve area less than 1 centimeter squared, the index less than 0.6, and the dimensionless index, or the velocity ratio, less than 0.25. For mild, we're talking about the peak velocity across the aortic valve, 2.6 to 2.9. The mean gradient less than 20. The valve area greater than 1.5 centimeters squared. Index greater than 0.85. And velocity ratio greater than 0.5. If the valve is just thickened and mildly calcified, we talk about the aortic sclerosis. In that case, the peak jet is less than 2.5 meters per second. It's just a velocity. Just velocity. Nothing else for sclerosis. So the valve is thickened, mildly restrictive, but does not reach the level of mild stenosis. Okay? All right, so where it is. All right, so we're gonna I need to do some updates with you guys. Just
You had a job last week, bro, huh? You looking for you, couldn't find you, man.
Are you sure you saved it? Do you have it in there?
Yeah, I'm checking.
All right, there's some, especially for people who are doing exam, there's some stuff that I need to go over. Or if you want to just email me those slides. All right, so this is one thing if they wake you up in the middle of the night, you should be able to recite everything about aortic stenosis. Because it's very, very common. It's really common. This is one, as a technician, you are expected to evaluate aortic stenosis. Very, very accurate. Because a lot of patients will leave from the echo lab to the operating room. So you can't, be shaky in your evaluation of aortic stenosis. Okay? So, and it has been shown to be very, very accurate. Once you multiple windows, serial examination, once you get to severity, where it's severe and the patient is symptomatic, the patient needs to get the valve replaced. As I say, Monday is a very exciting day for us. We have one of our cases, we're going to do a TAVI. Okay? So this is the guy that I've been following for a number of years, with echo, of course. And his mean gradient over the last few months shot up to close to 80. So that's the mean gradient. So that's very, very high. And he's symptomatic. He has had a couple bouts of heart failure, plus effort intolerance. The reason why we're going to do TAVI is because he has multiple medical problems. He's not in his early 80s, but he has multiple medical problems, and the team, it's a team approach, it's not a one-person approach. The team thinks he's best suited for a transcutaneous valve placement. So we're going to do a trans-aortic valve implantation. So, all right. So these slides were put in specifically for Greg, and they're going to show up on the exam. It was sent? So, and another important thing, if you, because you're going to have patients coming in, and is this a bicuspid aortic valve, or is it a normal tricuspid aortic valve? Short axis at the level of the aorta. If it opens and it looks like it's in a football configuration, probably bicuspid. Okay. You cannot go when the valve is closed in diastole, because you'll have what they call a raphe, which is a ridge, which will mimic a commissure. So it will look like there's 3 leaflets in diastole, but when it opens, it doesn't open in the triangular fashion. Some other thing that you can do is your MO. I will show you when we do MO. We'll show you. For a bicuspid aortic valve, the closure line is eccentric. I will show you what that means. Closure line is eccentric. Also, in your parasternal long axis view, in diastole, with a bicuspid aortic valve, you have what we call diastolic prolapse. So the leaflet prolapse in diastole. Okay? Remember, the aortic valve closed in diastole, so it prolapses backward, and you can see that. In systole, you get a systolic dolmen. So when it's supposed, remember, it's supposed to open fully, you get systolic dolmen. And we will go over those things and see. All right, so we're gonna look at the slides for Greg's. Greg is doing exams, so we're gonna take the time to go over that, and then you guys who are doing exams in the distant future also going to be beneficial. So these are just some of the things that they love to bring on the exam.
You've got mail.
Okay, so got that. All right, so this is continuation of, let's see, all right.
Click enable editing.
What's that?
Click enable editing at the top first.
So the new slides are where the new slides? All right. 20.
24.
24. Okay. All right. So, okay. So, Greg. Yes. So, bicuspid aortic valve, the diagnosis. Okay. So you have 2 cusps instead of 3. But remember, when it's in diastole, the raphe will give the impression that there are 3 cusps. So don't assess bicuspid aortic valve only in diastole. Look in systole. So 2 two cusps are seen in systole in the short axis. Now, the short axis, the aortic valve is open. Two cusps are seen. In the long axis, as we mentioned before, you may get asymmetric closure lines. So, and not only that, but you get systolic doming. So it bulges out in systole. And then you get diastolic prolapse. So in diastole, when the valve closes, it bulges back. Okay? So 2 cusp instead of 3. Important though, it is, remember we said that in the United States and Europe, it accounts for about 50% of patients going for aortic valve replacement. And over time, if you evaluate someone in their 50s and 60s, you get heavy calcification of the valve because of abnormal flow dynamics. They become calcified and restricted. In children and adolescents, you can get stenosis without extensive calcification. So just look at the valve. If it's not opening properly, and you look in the short axis views and it's a bicuspid, you know, that might be the reason. Okay? All right.
Let's put
let's do that. So, hello?
Yeah, I got a question.
Yes, sir.
One sees lumen and there is no stenosis.
What is that?
If one sees systolic leaflet,
Yeah.
external axis,
Yes.
there is not one assume that it is coming.
You broke up that's Terrence, right?
No, nowhere.
Oh no, sorry. Okay, repeat that.
I said if there's a domain of the aortic valve in the long axis,
Right.
and there is no stenosis, can see that the coming
Well,
at the annual.
yeah, so you don't have to have stenosis with systolic doming.
Right.
Right. But you know, you have to go through the maneuvers and look at everything, the velocity, mean gradient, your measurement via the continue.
No, I said the question is at that point, assume that the analysis is becoming restricted.
No. You have to go through. You can't say it's restrictive unless it is restricted. So if there is, no, you cannot say the annulus is restricted. You have to have objective data to say that it's restricted. Okay, you cannot just look. You can't just look at it and say it's restrictive. You can describe what you see, systolic doming, stuff like that. But if your mean gradient, your peak velocity, and the valve area comes out normal, then there is no restriction. All right, so let's move on. So for rheumatic AS, okay, so for rheumatic fevers, as we said before, worldwide, rheumatic AS is more common than bicuspid AS. But in Europe and North America, it is bicuspid AS. So it's more prevalent worldwide and is accompanied by rheumatic mitral valve changes. So if you're going to have rheumatic aortic stenosis, the patient will also have rheumatic mitral stenosis. Okay?
They will have both.
Yes. So with rheumatic AS, you get commissural fusion, and the systolic orifice is triangular. Okay? So unlike your bicuspid where it's a football shape, in rheumatic it's triangular, and you get commissural fusion. Okay? Important distinguishing feature. Okay, so you can have subvalvular AS, subvalvular AS, and it can be either fixed or dynamic. And when we talk about a fixed subvalvular aortic stenosis, we talk about a membrane or a muscular band, just where you have the outflow tract. Sometimes there's a membrane, and or just a muscular band that's what's causing the stenosis or restriction to the outflow tract. And you know, I've had a patient that I thought was a dynamic obstruction. T didn't show it. We actually had to use the CT scan didn't show it. We actually had to use a three-dimensional T to see the band. TE, yes. And then we have the dynamic subaortic obstruction with HCM. So these patients usually behave different, but those are some of the subvalvular cause for AS. And then supravalvular AS, so now it's above the valve. And the Williams syndrome, these patients have a peculiar phenotypic. They look very distinct, and that group of patients usually have supravalvular AS. So some of the sources of error for pressure gradient calculation, Greg. Okay, so we use the mean gradient across the aortic valve to determine severity. We said mean gradient greater than 40 millimeters mercury suggests severe AS. But remember now, gradient is dependent on the velocity, right? The velocity is dependent on the flow. So if you have a situation of low flow, the velocity is going to be low and the gradient is going to be low. If you have a situation with a high flow, the velocity is going to be high and the gradient is going to be high. And it's going to mess up your assessment. So you have to understand the limitation of using the pressure gradient calculations. So that is why you want to scan from multiple windows. You want to get the maximum velocity that you can get. The flow, the beam has to be as parallel to flow as possible to get maximum velocity. Because if you get a low velocity, it's going to give you a low gradient. And you're going to misrepresent the stenosis. All right? Another source of error is if the patient has significant mitral regurgitation. So if the patient has mitral regurgitation, it can mix with the aortic stenotic jet and give you a false higher gradient than the patient actually has. Because remember, they are both systolic flow. Mitral regurgitation is a systolic flow. Aortic stenosis is systolic. So you have to know how to distinguish them. Important, the mitral stenosis jet have a broad base. We talk about there's no IVRT in mitral regurgitation.
We ran into that a couple times.
There is no IVRT. There is no isovolumic relaxation time in mitral regurgitation. In aortic stenosis, yes, you're going to get your aortic stenotic jet. Then there's a time interval. Then you're going to get your mitral inflow. There is an IVRT. So the mitral, and we go over this and ask the technicians who are teaching you to show you. So mitral regurgitation jet is a broad base, as opposed to aortic stenosis is a narrow base. That when we say base, we're talking about the time at the top. Okay. Another with mild aortic stenosis, you get an early peak, and we'll show you that. With severe aortic stenosis, however, you get a later peak, and sometimes the contour is rounded. It's rounded. But it's a source of error when you have mitral regurgitation. It can mix with that aortic stenotic jet and mess you up. Remember, mitral regurg usually have a velocity 5 meters per second or more. So, you know, once if you start getting in a ridiculously large number, think in terms of Greg on the exam. All right. The pressure recovery phenomenon is also a source of error. And you get pressure recovery usually in individual with small aortic root, less than 30 millimeters. Small aortic root. And what it means is that when the blood flows across the narrow aortic orifice, it transforms potential energy before it gets through the aortic valve. That potential energy is converted to kinetic energy because of the narrow aortic orifice and the increased velocity. So you have increased velocity, increase in pressure. But some of that pressure lowers because that kinetic energy is converted to heat and because of viscosity. So some of that kinetic energy is lost. When it gets into the aortic root, the kinetic energy is converted into potential energy and the pressure is recovered. So pressure recovery is also another source of error. It only comes into play if the aortic root is less than 30 millimeters. So most of our aortic root is probably, the ascending aorta is probably more than 30 millimeters. Okay. Doppler also measures maximum instantaneous pressure. Okay? The Doppler doesn't measure peak to peak as in your cath lab. So maximum instantaneous pressure. Another important point is when you have aortic stenosis, remember we say we use the gradient, the velocity flowing across the valve. Gradient is 4v squared. If you have severe MR and the ventricle contracts, blood is going to go into the area of least resistance. So a lot of that blood is going to go back into the atrium. So you're not going to get a lot of forward flow across the aortic valve. So that velocity or that flow across the aortic valve is going to be lower, and hence the gradient is going to be lower. So you're going to get a falsely low gradient. You know, if you were to fix that mitral valve, then all of a sudden the gradient is going through the roof. So you have to bear that in mind. With severe MR, you can get a falsely lower gradient across the aortic valve because the blood is preferentially shunted into the low pressure area. That is the left atrium. So there's low flow across the aortic valve, low velocity, low gradient. Okay? Also, situation where you have high cardiac output. Anything that increases the cardiac output, increase the velocity, and hence 4v squared is going to be increase the gradient. So things such as hemodialysis. Patients on hemodialysis, because you have shunts, those shunts increase cardiac output, increase the velocity and the gradient across the valve, falsely increasing the gradient. Anemia and any situation where you have AV fistula, sepsis, anything like that with increased output is going to falsely increase that gradient. So you have to bear that in mind. All right? All right, so the limitations of the continuity equation. Remember, I tell you to cite the formula. Aortic valve area is equal to 0.785 times D squared times LVOT TDI divided by aortic valve TDI. You can recite that midnight. Wake up. But remember, you're measuring that diameter, parasternal long axis, that LVOT diameter. But you're not only measuring it, but you're squaring it. So just measuring it, there's a 5 to 8% error. But when you square that 5 to 8%, it's even much larger. So this is where you have the greatest potential source of error in the content equation. And you're going to get it correct. It's on the exam already. I'll tell you that. Okay? All right, good. All right, so we talk a little bit about planimetry. It's inaccurate with valve calcification, and you have to try and ensure that you're going to get minimal orifice area, and it's difficult sometimes because you don't know if that is the smallest, or so we do it, but it's not very accurate. Okay, so great, you're going to get this on the exam. All right, so there's a situation we call low flow, low gradient AS. Okay? Low flow, low gradient AS. What does that mean? Basically, what it means is that there's a group of patients who have depressed left ventricular systolic function. The left ventricular systolic function is depressed, and they also have some aspect of aortic stenosis. But because the heart is not pumping strong, the valve is not opening to its full extent. So how do you distinguish, is this severe aortic stenosis or it's not severe aortic stenosis? It's very important because those patients who have a depressed LV systolic function because of the AS, they will improve just like that when you remove that valve, when you replace the valve. Those patients are going to rebound and do very well. So there's a group of patients that the reduction in the ejection fraction is as a result of the increased afterload of the AS. And once you remove that valve, you replace that valve, they do very well. However, there's another group of patients who also have some aspect of AS, probably not severe, but they have some other cause for LV systolic dysfunction, right? They may have concomitant coronary artery disease. They may have alcoholic cardiomyopathy, viral cardiomyopathy. But because the heart is not contracting strong enough, the valve is not being open. So when you calculate, when you do your gradient, you're going to get a low flow situation. So we define a group of patients with low flow, low gradient AS as when we do our initial assessment, they have a valve area less than 1 centimeter squared. The EF is usually less than 40%, and the mean gradient is between 30 and 40. So this doesn't match up. Because we talk about a severe aortic stenosis, valve area less than 1 centimeter squared, and a mean gradient greater than 40. So this group of patients, when we use our continuity equation and we calculate the valve area, it comes out to less than 1 centimeter squared. But the gradient is low. And these patients have a decrease in their ejection fraction. So this is a group of patients we describe as low flow, low gradient AS. I would say there's 2 scenarios that can give you this picture. Patients where the AS is causing the depression in the LV systolic function, and then a group of patients who really don't have severe AS, but they have some other reason for their depressed LV systolic function. We have to try and distinguish that. So all right, so severe AS causing the LV dysfunction. AVR will lead to improvement, so that. And then the second group is those with moderate AS and another cause for the LV dysfunction. So we can use a Webber stress test to distinguish these 2 group of patients. It's on the test spread. So the Webber stress test can distinguish these 2 group of patients. And we use low dose Webber. We use a dose of 2.5 to 5 milligrams per kilogram per minute. When we're doing the regular Webber stress test, we use 5 milligrams per kilogram per minute up to 40 or 50. But this is low dose dobutamine, 2.5 to 5. And we're going to increase the dose every 3 to 5 minutes to a maximum of 10 to 20 milligrams per kilogram per minute. With a regular dobutamine stress test, we go up to 40 or 50. This is a low dose, okay? So the dobutamine stress test will distinguish these two groups of patients. We're going to stop the infusion as soon as a positive result is obtained, or the heart rate increase by 10 to 20 beats per minute above the baseline, or if the heart rate exceeds 100 beats per minute, then we'll stop the test. We're going to measure aortic valve velocity with each increase. We're going to measure the mean gradient and the valve area and the ejection fraction. So those are the 4 parameters that we're going to measure. So if your dobutamine stress test shows that the area is greater than 1 centimeters squared, then the AS is not severe. And the LV systolic dysfunction was due to something else. This patient is not going to benefit from aortic valve replacement. However, if the aortic velocity jet is greater than 4 meters per second, if the mean gradient increased to greater than 40 millimeters mercury, it suggests severe aortic stenosis. And these are the group of patients that are going to benefit from aortic valve replacement. Another important point with the dobutamine stress test. Failure of the stroke volume or the ejection fraction to increase above 20% is a predictor of high surgical mortality or poor long-term outcome. So these are the group of patients that will not do very well during the surgery or long-term. So it gives you a group of patients who is not going to do very well if the ejection fraction of stroke volume doesn't increase above 20%. All right, so we're going to take a little break here, okay? So Greg, you have about 20 questions that's going to come in there. So we're going to take about a 10 minutes break, and then we will go into aortic insufficiency. Any question, Lenny, Noel, Terrence?
Well, none for now.
I mean,
Straightforward, sir. Huh? Straightforward.
Very.
No, the important thing is when you're doing your scanning, make sure that the technicians, you know, do all these maneuvers and tricks and stuff.
yeah.
Oh. He's there?
Hello?
That's on?
Yeah.
Oh. Go and plug in. I mess up. Eh? And click the thing quick by the thing.
That's why I put up there.
Oh, okay.
No, I always put
Yeah.
you did it last night, that's why.
Oh, I think was.
No, we just
Great
added it.
special.
No, we just added it.
Oh.
So that's why, you don't know. I
Yeah.
don't know what happened, why this thing,
What
I I added it last night and somehow.
Yeah, I should. Yeah, I should. Yeah. One thing.
I forget to put my something in the fridge.
Arthur,
Yeah, what happened?
that's it.
Okay.
What happened there?
Oh, but where are you supposed to email us? That's the kind of stuff you're supposed to email us.
Noel,
Yeah.
one of the stuff where you say you have to email us.
You want to can't find it.
Oh, okay.
Thumbs up, you know?
Yeah.
Yeah, somebody get you yard. From reach out. No, I said somebody come through.
Oh,
Yeah, so through that number.
yeah. I'm saying somebody. Yeah, all right.
Don't forget.
So everything good?
No, nice one with it.
You nobody show off for me. Chew me off a bungle up now, man. Eh?
What's that you wearing? A sweater?
Tell him 3 shirts.
A tree shirt. You know, see a tree shirt me have on. Look what tree me have on. I have a sweatpants under this too.
You know what I'm wearing.
It's alright. But come down there now. Mr. Who come down there, you know?
T-shirt and shorts, Arthur.
Yeah, you know.
Hush.
That's what you know that too, man.
Yeah, man, you said very cool.
Yeah.
Hush.
It has 17 degrees this morning. And we'll get some more snow later. I'm saying next time.
Oh, great.
Yeah.
Fun.
Yeah. All right. Eh?
Oh, you are the scanning.
Well, pretty good, you know. Me take up some of your things them where you tell me. So me I do good now, you know?
That's nice.
Yeah.
What happened to Michelle?
Michelle, she sit around us like she have cola or something.
I'm coming along, Noel. I'm coming along.
Yeah.
I'm coming along.
She coming along. You know, so she's very competitive, so, you know.
You coming along, honey?
Yes, I am.
Come.
That's good. My ginger. You sound like you could use some.
Huh?
I say you sound like you could use some ginger tea.
I could use more than some ginger tea, my dear.
I know. Yeah, too greedy. I'm full. Yeah.
Making sure that this is right now. Just did it.
So Dr. Forrester.
Yeah.
What are we doing later?
It depends on. Get out of here.
What time can you?
I probably won't get out of here. I will try to finish.
You give an idea what time? Do you have an idea what time that might be?
Outside. I'm outside. 4:35.
Excuse me? Can you say that again, please?
Oh, Jesus Christ. What happened here?
Bring back that time.
Oh, God. Oh, give me spring clean.
Michelle,
Yeah?
is there a particular problem?
No, I'm working on the spreadsheet, the thing, and it looks like I put the stuff in the wrong place. What are you saying to me now? Is there some, what? I'm sorry?
Is there a particular window that is giving you a problem?
Giving me problem?
Yeah. Are you better? You want to do improvement?
You always want to do some improvements, you know?
No, I'm saying, is there a window that you so desire?
Oh. I think the issue that I'm having is the rotation.
Where to?
Like when I get to in the power, no, it's not always constant, because sometimes I'll be at 4 and it's no problem to rotate to 3 and 2.
Hold on. You're talking the ethical.
Yeah.
All right. So
Yeah. No, not the, yeah, the apical, sorry, yes.
All right. So you say when it's moving from the 4 to the 5 to the 2 to the 3 to the 3?
Yeah.
Okay. All right. I'm going to solve the problem for you.
Please do.
All right. Listen. Listen. You find the 4. If you look at the and you look at the rib cage, it has a ridge. You can picture that?
Yeah.
Right where it leaves from the chest to the underarm. You see that little curve right there? That ridge on the curve?
Yeah.
That's where you're gonna put your probe.
Okay.
So you go anywhere you get a long axis. Make a diagonal right to the ridge.
Okay.
And then you should pick your fork up right there.
Okay, so you know what? When I'm doing it later, I'm gonna call you.
No, just listen on there. If you have a, you see, you make a diagonal. You're gonna, if you're right, the area.
Okay.
All you gotta do now is move your probe in a circle and you should have a picture.
Okay.
Alright?
I shall try that.
Yeah, and then your forward, your tail to your right, your foot, 5.
No, 5 I have no problem getting.
Alright, well, clockwise to 2.
And 2 is not, I just think sometimes the rotation from the 4 to the 3.
4 to, no, you can't go. Do not go from the 4 to.
Oh, so that's what we've been doing.
No, you gotta go from 2. Then to the 2.
Oh, let me write that down.
When you find your
Yeah.
Go further anti-clockwise like a helicopter.
Okay.
Go more anti-clockwise.
Okay.
And you find your tree there.
Oh, okay. That makes sense.
All right.
Thank you.
So you go, yeah. So you go 4, 5, 2, 3.
Oh, okay.
All right.
Okay, thank you.
All right, Miss.
Oh, I should go eat some.
Chair.
All right, we're going to start back in.
I'm gonna try to send.
Okay.
Right.
I didn't send it.
Oh, okay.
Because I'm having a problem.
Start back in a couple of minutes.
I'm trying to save this thing directly. I'm losing my mind.
Wait, come on.
Still a little on that passive resistance when you're coming off the aortic root with the pressure less than 30. I'm still a little confused about what's happening.
Okay, you get the pressure falls and then recovers.
Right.
So it's increased. The pressure increase. So remember, it's a pressure gradient you're measuring.
Right.
So if the pressure increase, the gradient is going to be lower.
Right.
So when you have a stenotic valve, okay, when the blood approaches the valve,
right,
the potential energy is converted to kinetic energy because it's now going through a narrow orifice.
Right.
So the velocity increase.
Correct.
So the potential energy, which is equal to half mass times velocity squared, increase. But some of that potential and kinetic energy is dissipated,
it's lost in
heat and viscous.
Right.
But because of the narrowing, it is converted back into potential energy and the pressure increases.
Okay, because it's 30 or less.
Less, yes.
And because it's tight.
Yeah.
So you have an increase in speed, you lose your kinetic energy.
Yes, there's converted.
Potential,
Yeah.
and then so
the pressure recovers.
All right.
So there's a formula that you can use, but we can go over that at some other point.
That's esoteric.
Yeah. But it's only become significant when the aortic, the ascending aorta is less than 30 millimeters. All right. So we're going to start back, guys, and we're going to do valvular insufficiency. All right. So when we have aortic insufficiency, there's a backflow of blood from the aorta across the aortic valve into the left ventricular cavity. Some of the signs and symptoms with aortic insufficiency: you get shortness of breath, exertional orthopnea, patient cannot lie flat, paroxysmal nocturnal dyspnea, patient go to bed, wake up in the middle of the night because they're short of breath. Palpitations, fairly common, chest pain again, third heart sound, and the classic murmur associated with aortic insufficiency is a blowing diastolic murmur heard best at the left sternal border. We call that a decrescendo murmur. You get the sort of bounding pulse. Okay, we have the same problem again. We have too many of these things, huh?
Here's their pumpkin, guys. It's 500. Right there. No, it's updated on this.
Oh, it's updated. This thing just malfunctioning. So aortic insufficiency is also very common. So as echocardiographer, you need to know how to assess AI, as it's commonly called, and then you have to know when you should send these patients to surgery. But echo is the best tool to evaluate aortic insufficiency. So what you should realize by now is that the hemodynamic lecture you can just apply to these valves. So that is why it's very important for you to understand hemodynamics. And that's why we spend a little extra time on the hemodynamics. All right. So some of the causes for aortic insufficiency: aortic root dilatation. So if the root is dilated, there's poor coaptation of the valve, so there's going to be backflow. Syphilitic aortitis, when this was common, when syphilis was common. Syphilitic aortitis, inflammation of the aorta from syphilis. Aortic dissection, that's when you have a rip in the wall of the aorta, which can, the tear can go all the way back to the valve and make the valves incompetent. So that's also a cause for aortic insufficiency. Hypertension, okay, there's increased afterload, the valve doesn't coap properly, and then there's a backflow of blood. Bicuspid aortic valves, it not only can cause aortic stenosis, but it can also cause aortic insufficiency. And then we have a condition we call mix. So if you have moderate aortic stenosis and moderate aortic insufficiency, that is severe combined valvular disease. That valve needs to be fixed. So even though both is moderate, it's a severe combined valve disease, and you need to fix it. Rheumatic fever, not only rheumatic fever, but not only. Everything okay with you guys? So rheumatic fever can also cause aortic stenosis, and so can cause aortic stenosis and aortic insufficiency. All right. This just jams over.
Whenever you get your tempo on it.
All right. Okay. So we have, so the causes continue. Endocarditis, that's inflammation of the valve, and hence render the valve incompetent. Medications, remember those diet pills, fenfluramine, they can also cause inflammation of the valve and regurgitation. Marfan syndrome, very important, Greg. So you get aortic root dilatation and some of the other features, skeletal, connective. Skin.
Abraham Lincoln. They said that Lincoln, he had Marfan.
Right. So you get skeletal deformity, scoliosis, and then you can get lens deformation, lens dislocation. So Marfan syndrome, very important. So you can get not only aortic root dilatation and aortic insufficiency with Marfan's, but you can get aortic dissection. Okay. Ehlers-Danlos, which is a similar type of syndrome. Ankylosing spondylitis and systemic lupus erythematosus, SLE. Okay, so these are some of the more important causes for aortic insufficiency. The evaluation of the severity. So you're going to look at a number of things. In the parasternal long axis view, you're going to look at the aortic insufficiency jet. Remember, this is our parasternal long axis right here, okay? Okay, this is our septum. The posterior wall is down here. This is the mitral valve, so anterior mitral leaflet, posterior mitral leaflet. This is our aorta right there. The aortic valve is there. It's a little bit thickened, okay? But this is diastole where the aortic valve is supposed to be closed. And it looks like it's closed, but there is blood going back from the aorta into the LV cavity, or transducer right here. Flow away from the transducer is blue. The transducer is there. This is our aortic insufficiency jet. It moving away from the transducer, hence it's blue. This is our LVOT diameter. And if you measure the width of the AI jet, and if you put the width of the AI jet, to the width of the LVOT, if that ratio is greater than 65%, greater than or equal to 65%, the AI is said to be severe. If that ratio is less than 25%, then it's said to be mild AI. Okay? So the width of your AI jet to the width of the left ventricular flow tract, if that's greater than or equal to 65%, the AI is severe. If it's less than 25%, then it's mild. Anything that falls in between is moderate. Okay? We also can do what we call the pressure half-time evaluation of the AI. So in the 5-chamber view or the 3-chamber view, this is a 5-chamber view. So our 2-dimensional echo is up here. And this is our Doppler echo. It should be done with CW. The cursor is right at the aortic valve. There's aortic insufficiency, which is depicted as a diastolic flow, diastolic flow, diastolic flow. So you do what we call the pressure half-time. So the pressure half-time is time it takes for the pressure, the maximum pressure to fall 1/2. So it's the time it takes the pressure, the maximum pressure to fall to 1/2. So the computer do all of this for us. So this thing is very sensitive. So we drop on the slope. We put our signal right on the slope, and the computer will give you a pressure half time. So this pressure half time, P half, is 799. Okay, so in assessing for AI, you're going to look at the pressure half time. If the pressure half time is greater than 500 milliseconds, it's mild. If it's less than 200 milliseconds, then it's severe, steeper slope. Okay, so the pressure half times the time it takes for the maximum pressure to fall on half. Okay. We also look at the density of the aortic insufficiency adopter signal, and if it's very, very dense,
Right.
bone dense, then it suggests severe. If it's light like this, it suggests mild aortic insufficiency. So we look at the jet width, we look at the pressure half time, and we look at the density. You have to know all the parameters that make.
So the pressure half time, do we measure that?
No, well, the AI occurs in diastole.
Okay.
AI occurs in diastole, so it has to be measured in diastole.
Okay.
Okay, so this is you can see here. This is on the top. You have mild aortic regurgitation. On the bottom, you have severe. And if you just eyeball it, you have a small jet in diastole here. And remember the ratio of the width of the jet to the width of the LVOT diameter. If it's less than 25%, it's mild. If it's greater than or equal to 65%, it's severe. Look at the bottom. This is this is a broad width. Very broad, right? Everybody can see that?
Yeah.
So that's greater than or equal to 65%. That suggests severe aortic insufficiency. And then now if we look at the C-doubler signal, when we look at the C-doubler signal, see, it's not bright, it's not dense, and it's not very steep. See that? As compared to this one, it's bone dense and it's very steep. So pressure half time less than 200 suggests severe, and if it's very dense, so also suggests severe. Pressure half time greater than 500 milliseconds suggests mild. And then if we look at our descending aorta, remember this is done via the suprasternal notch. So if we look at our descending aorta, and you get what we call diastolic flow reversal, okay? So this is systolic flow, and you have almost nothing here in diastole, okay? Everybody can see that? Okay, with severe, you get an diastolic flow reversal in the descending aorta. So all through diastole, the flow is reversed. You're supposed to get a little bit of flow down here in diastole, okay? Systolic flow, suprasternal notch, a little bit of diastolic flow here. With severe aortic insufficiency, diastolic flow reversal. It's now above the baseline, and it's all throughout diastole. Suggests severe aortic insufficiency. Okay. Remember when we did hemodynamics with the pizza? Okay. So you have blood flowing across the aortic valve from the aorta, across the aortic valve into the LV cavity. So it's going to set up a series of concentric rings above the aortic valve because the regurgitation is going into the LV cavity. So remember what we showed is that the regurgitant flow is the same thing as the flow of pizza. Okay? So we can calculate, or we can look at the effective orifice area, and we show you how to do that. So if the effective orifice area is less than 0.1, it suggests mild AI. If that effective orifice area is greater than or equal to 0.3 centimeters squared, it suggests severe AI. And when we do MR, if it's greater than 0.4 centimeters squared, it suggests severe MR. And if it's less than 0.2, it suggests mild.
So I get this straight. When you do it for MR at PISA, you change the color, you change color.
The baseline shift you're going to change.
Right?
Yes.
And then you put the thing there in the little mushroom.
Concentric, yes.
Right.
Right. So that's the flow of pizza.
Right. Now that's for MR.
Yes.
Right? Above the valve.
Yes.
Where would you do that?
The same thing. So it's going to be the so you have aortic insufficiency.
Right. Coming out of the.
Right. So you put your cursor above the aortic valve, and you'll get these concentric, and then you do your baseline shift to get your Addison velocity. So you want to adjust it to get those nice concentric rings that we talk about. All right, and then you calculate your EROA. So if you need to go back to your hemodynamic lecture to see how you do that. Okay, but it's simple. The flow at pizza is equal to the regurgitant flow. Flow is equal to cross-sectional area times the velocity. Okay? So if you're going to use your concentric ring, the area is 2 pi r squared times the Addison velocity. That's give you the flow at pizza. The Addison velocity is what you adjust on the machine. And that's going to equal to the regurgitant flow. Regurgitant flow is equal to the area, effective regurgitant orifice area, times the velocity. That's going to be the AI velocity. Okay? And then you can calculate your EROA. So EROA, effective regurgitant orifice area, greater than equal to 0.3 centimeters squared suggests severe AI. If it's less than 1 centimeter squared, then it's mild. You can also get something what we call a vena contractor. So remember, when you have regurgitation, it's going to go through this potential area, right? The blood is going to flow back through this column. The column has an area and it has a width. So the vena contractor is the width or the length. So if that length is greater than 0.6 centimeters squared, suggests severe. If it's less than 0.3 centimeters squared, sorry, not centimeters squared, it's a width, it's a length, so it's centimeters. So if it's greater than 0.6, it suggests severe AI. If it's less than 0.3, it suggests mild AI. Okay? From the pizza, we can also calculate the regurgitant volume. Remember, we show you how to do that. So if the regurgitant volume is greater than 60 mLs, it suggests severe AI. If it's less than 30 mLs, it suggests mild. And then regurgitant fraction. If the regurgitant fraction is greater than 50%, it suggests severe AI. And if it's less than 30%, it suggests mild. Okay? So these are the parameters we use to determine the severity of AI. We talk about the width of the regurgitant jet, greater than equal to 65% severe, less than 25% is mild. We talk about the pressure half time and the density of the regurgitant envelope. If the pressure half time is less than 200 milliseconds, suggest severe. If it's greater than 500, then it's mild. And we also then we look at the PISA method of doing it. Okay, the PISA method allows us to look at what we call the vena contracta. That is the width of the regurgitant jet. We also can look at the EROA, effective regurgitant orifice area. We can look at the regurgitant volume and regurgitant fraction. And you have to know what is severe in these different parameters. So for the vena contracta, anything greater than 0.6 centimeters is severe. If it's less than 0.3, it's mild. For the EROA, if it's greater than or equal to 0.3 centimeters squared, severe. If it's less than 0.1, it's mild. Regurgitant volume, if it's greater than 60 mLs, it's severe. And if it's less than 30 mLs, it's mild. And then regurgitant fraction is 50%. Greater than or equal to 50% suggests severe, and less than 30% is mild. So this is a table which goes over all of that. So you can walk around with this table, and it's basically the same thing we just described. So you know what's mild, you know what's moderate, anything that falls in between. Sorry, you know what's mild, you know what's severe, anything falls in between is moderate. Okay? So this is the table, and I suggest all of you guys study it, know it inside out. Okay? All right, so you have to know what's mild, what moderate, what's severe, and then what falls in between. So let's just go over the table. For severe, okay, we talk about the width of the regurgitant jet. If it's greater or equal to 65%, the vena contracta greater than 0.6 centimeters, pressure half time less than 200. Remember the Oler diastolic aortic flow reversal in the suprasternal notch. Greg?
It's PW now, right? You evaluate that with PW, it said PW on there. CW.
It's best to use CW because you don't know when you're going to see a very large velocity. All right, so but you're going to get that, Greg. It's there. The Oler diastolic flow reversal suggests severe AI. And then we talk about regurgitant volume greater than 60 mLs, greater than or equal to 60 mLs, regurgitant fraction greater than or equal to 50%, and the EROA greater than or equal to 0.3 centimeters squared. That's for severe. Then mild, the width is less than 25%, vena contracta less than 0.3 centimeter. You don't get your Oler diastolic flow reversal. And pressure half time usually greater than 500 milliseconds. Regurgitant volume less than 30 mLs. Regurgitant fraction less than 30%. And the EROA less than 0.1 centimeters squared. Okay. So we're gonna terminate here. Any questions? All right, so our next session we'll do mitral valve, and then after that is test exam, second exam. Any question, Lenny, Noel, Terrence?
No question. No question.
All right. So our next session we will do mitral valve disease, that's mitral stenosis and mitral regurg. Okay.
When you were doing the evaluation of the severity,
yeah,
right, and you said you take diameter of the regurgitant jet and the diameter of the
LDOT, yes.
That regurgitant jet, is that the same as the effective?
No, no. This is something you're going to see when. So it's going to be your blue color going backwards. You're going to measure that blue color, the width of that blue color.
So that wouldn't be the same.
No, it's going to be different. Remember the EROA is an orifice area, so it's an area, whereas this is just a one-dimensional thing.
Okay.
And
So
it's
you're
not
talking about the whole size of the valve. That's what you're talking about, right?
Hmm?
You're talking about this, where it's coming out of the valve.
Yeah, so the
That's where you're
cross-sectional
gonna-
area.
SVE, that's where you're going to measure that. SCE,
EROA, that's EROA.
is
the
this,
size of
and
the
then,
hole, basically.
and then this is just
Yeah.
this. Okay.
And then the other thing is the width of the
Right.
Well, it's not. You have to do your adjustments, though. So it's not just looking at that. It's just not looking at that. You have to make your shift in the Ailerson velocity to get your nice mushroom, and then it's the width of that mushroom. That's your vena contractor. So it's not just measuring the width of the color on the regurgitation.
Right.
There's more maneuvers that you have to do to get the vena contractor.
Okay.
Okay.
All right, interesting.
Any other
It's so
questions?
deeper, big, it's bigger, you know what I mean? It's deeper, very interesting. You spend a lifetime pulling that crap, right?
Over time, you'll get most of it. So.
Not that fixed.
It's not. Yeah. So it will vary with the severity. If it's very severe, so for instance, you were able to tear that apart.
Yeah.
Then there's more blood going back, so that area will get bigger.
Yeah.
So when you do your calculations, it's actually a calculated area.
Okay.
But studies have shown that it is the effective regurgitant area which will determine clinical outcome.
Oh.
You know, because I mean, yeah, you might have a nice big fat area, but it's the amount of blood going back which going to affect the clinical picture. All right, guys. Next session. Check the website for the next session. And Terrence, you there?
Yeah.
Okay, so we will talk because I mean you have some questions that you know we need to discuss it. So I'll when are you leaving? Okay, all right. So, give me a call before you leave, and we'll discuss your concern.
I wasn't been here before.
You're breaking up, Terrence. Okay, no problem. Sounds good.
I think that's work. I don't know if I've heard it, but a friend that must have not done
Right on time.
Hello.
We can't walk past your class. Like I was like, "Are you done?"
You text me?
Yeah, I
I had the
did.
volume down. I didn't see it.
Yeah. Zach's birthday was yesterday. We're gonna sing to him.
Oh, Zach's birthday?
Yeah.
Yeah.
Birthday.
So make sure you make Tom show you everything.
Yeah.
I need to move this machine. So.
All right.
Doc, you have to remember